Good morning, everyone. And on behalf of the Gojo team, welcome to the Gojo Symposium. My name is Megan DeGiorgio. I'm an infection preventionist and clinical manager at Gojo. We're so glad that you're here with us today. And my team, we're always really inspired by the dedication and passion of our guests who wake up early. Some of you were here at 5:15. I wasn't even here at 5:15, so thank you. And as we all work together to advance the science of hand hygiene, we're very grateful that you are here with us today. Last year, we asked the symposium attendees what topics they wanted to learn about. And behavior change was top at the list. As infection preventionists, we're charged with improving hand hygiene, yet we really have no authority or responsibility for those on the front lines of care. Today, we hope to present you with a fundamental change in approach. Our speakers will discuss why building partnerships is key to accomplishing change. Our first speaker, Dr. Jeffrey Ford, is a professor emeritus of management in the Department of Management and Human Resources at the Fisher College of Business at The Ohio State University. Prior to joining Ohio State, he served on the faculties at Rutgers, the State University of New Jersey, and Indiana University. His research focuses on the leadership and management of change, resistance to change, and the role of productive conversations in the implementation and accomplishment of change. His articles on organization change have appeared in numerous journals, including the Academy of Management Review, the Journal of Organizational Change Management, and Harvard Business Review. He is the co-author, along with his wife Lori, of the 4 Conversations, Daily Communication That Gets Results. During his presentation today, Dr. Ford will identify 4 key conversations that generate engagement, reduce resistance, and lead to successful change. Peggy Zemansky is the patient care manager in the surgical intensive care unit at the University of Chicago Medicine Hospital. She previously served as nurse leader at Parkland Hospital in their surgical trauma intensive care unit, and she also serves as a nursing legal consultant. Peggy's focus in leadership has been employee engagement and staff ownership, which has improved quality outcomes. Peggy recently received the Employee Engagement Excellence Award, and her surgical intensive care unit was awarded the Silver Beacon Award for Excellence in Nursing Care. She's published chapters in nursing textbooks and has presented on employee engagement and other hand hygiene topics. During her presentation, Peggy will illustrate the value in infection prevention working through nurse managers for the accomplishment of change. When her hospital installed an electronic hand hygiene compliance monitoring system, house-wide, Peggy had the challenging task of getting her staff to buy in to the initiative to own their hand hygiene performance and ultimately change the culture of their unit. And she will share her 4-year journey with us today. At this time, I would like to invite Professor Ford to the podium.
Good morning. So for those of you who don't know, Professor Emeritus means that I don't have any classroom responsibilities, I don't have any faculty meetings, I can do pretty much what I want, and I get season football tickets. It's really an honor and a privilege to speak with you this morning. I know the work that you do. This is my first introduction to the work that you do, and I know that it's important, and that I'd like to share with you some things that I think will support you in accomplishing the work that you do. As you already know, change requires that people act and behave differently than they're currently behaving. It's reasonable, therefore, that we would expect the way to bring about change is to focus on their behavior first. What if changing behavior is not the thing you should be focusing on? What if changing behavior is a consequence of what you're trying to accomplish rather than the source of what you want to accomplish? You've all heard the adage that it takes a village to raise a child. I'd like you to consider a similar idea required for producing change. What it means to take a village is that the villagers have to partner up with each other, that they have to work together, they have to work cooperatively, and in a very real sense, raise that child along with the parents. In a similar manner, it takes a village to raise or to produce a change in an organization. Change results because people interact differently in an accomplishment of change. So it's the interaction between people that becomes important, not necessarily what each individual themselves does. A partner is a person who takes part in an undertaking with one or more people in an endeavor to accomplish a particular outcome. They share the risks and the rewards. They form a partnership in that each shares in the success and in the failure. It's not my failure, it's not my success, it's not your failure, it's not your success, it's our success. When you hear Peggy talk, she's going to talk about ownership, and one of the things that's characteristic of is a partnership. There are four different partnerships that are available in the conduct of change. The first one is the partnership between the principals, the leaders, the managers of particular units that are undergoing change, and change recipients, the people who actually have to do the change. The second partnership is between the change agents and the principals. Now, in some cases, such as Peggy, the change agent is the principal, in which case we have a different dynamic, but in your case, you're not the principal. You have to work with principals and you have to work with change recipients. That's the one we're going to focus on today. The third partnership is between change agents and change recipients. And then the fourth one is the relationship among all three, which is the ideal kind of situation. The reality is in organizations that some of these partnerships are strong and some of these partnerships are very weak. What makes it particularly difficult for you is if the relationship between the principal and the change recipients is weak, it compounds your problems. Now, what does change typically mean? What it typically means for people is I want you to do something differently than you're doing. What I'm doing is fine, what you're doing is not. In their world, what you want is an interruption. This is not really a partnership. This is more like a dictatorship where you're supposed to do what I want you to do. I've learned over the 40-some years that we've been doing this kind of work that most people do not think they need to change so much as the people around them need to change. Principals think recipients need to change, and recipients think the principals need to change. There is very little we in current approaches to change. Typically, people want to know, as soon as you bring up a change, what for or why? What's wrong with what I'm doing? People generally take an orientation that's kind of reflected in this cartoon. We tend to think that that we're eagles and other people are the turkeys. It's where I know it's a situation where I know what you should be doing. If you would just listen to me and do what I am saying you need to do to accomplish this thing I think you need to accomplish. Change implies that something's wrong, or that what I'm doing is wrong in some way, where that something is not what it should be, or it's not the way that it shouldn't be. Why else would you want me to change? Because if it's already successful and already works, why would I have to do anything differently? In this regard, changes are seen as critical of something I am or am not doing. And therefore, I have to be fixed or repaired in some fundamental way, which means I'm working on what has been as compared to what could be. I don't know about you, but as soon as someone suggests, particularly if it's my wife, or even hints that I may be doing something wrong, I become defensive and begin justifying and explaining my actions. It's no surprise, therefore, that the overwhelming majority of changes undertaken in organizations at all levels, from the individual all the way to corporate level, fail. It's not that they don't produce any results at all, it's that they fail to produce the results that people intended them to produce when they started. Now, it doesn't have to be that way. This particular statistic has held up for decades, but we've learned that it doesn't have to be that way. Unfortunately, the way we generally approach change sort of persists this kind of result. So I'm going to talk to you about some ways of gaining access as a change agent with regard to primarily principals, but it also has an impact on change recipients. Our research over the last 30 years has shown that there are 4 types of what we consider to be productive conversations that are involved in the implementation of change, what we call initiative, understanding, performance, and closure. Although the specific subject matter may change, college professors, business professors talk differently than you all. The conversations that we use to accomplish what we want to accomplish are nevertheless the same. We're currently in one of those conversations, and that conversation is a conversation for understanding. I'm going to present these conversations in a sequence, but you should know that in the real world, they don't occur in this order. They occur as they occur, and they have to be used when it's appropriate. So what do I mean by these different conversations? If you're going to initiate a change, you're going to start with what's referred to as an initiative conversation. This is a conversation for what could be. What is it that's possible that we could accomplish? It's a conversation for creating and proposing a future as compared to fixing a particular problem. Initiative conversations speak for a future that people are interested in and committing to change. These are conversations that focus on what you want or what the change is for, the time frame and what you want in the time frame in which you'd like to accomplish it, and the rationale or the reasoning behind it. The purpose is to create a future, and it's to create the future now that we can begin working on together now. Which of the 2 futures would you like? These are both the same future. They both produce the same result. Which one do you find more attractive? How many of you prefer treatment A? So how you speak of future matters. Initiative conversations are organized toward what it is we want to accomplish as compared to what we want to stop or what we want to prevent. I was watching the other day a show on Mr. Rogers, and they went through the methodology he used for how to talk to for preschool children, how to change an idea that was negative into a positive kind of thing. I thought he should make that available for all of us. There's a study done by a man named Alan Weissman that was published in Fast Company, and he also has a book out. Most people believe that they were confronted with a life or death situation and they had to change in order to stay alive, that they would. He did a report on people who had triple bypass surgery in which they were told that if they did not change their behavior, they would again endure a painful and possibly a premature death. How many people do you think changed? None. The odds are 9 to 1. The scientifically looked at are 9 to 1 that even in the face of death, people will not change their behavior. It was not until they started talking about what would be available, like a future, the quality of life and the things that they could enjoy if they would change their behavior, that they actually did. So focusing on fixing something doesn't work as good as focusing on building something. Understanding conversations, like what we're beginning now, are the conversations in which we involve people and engage people. These are the conversations that we have most of the time in organizations and around change, because we're trying to get people to understand what we're doing and why we're doing it and how we're going to do it, on the belief that if they understand all that stuff, something's going to happen. In change, there are always 2 points of view. This is a source of difficulty and resistance. There's the change agent and there's the change recipient. They don't see the same things the same way. My good idea is not necessarily your good idea. This is where people will tell you things like, well, but I didn't touch anything. The dispensers were empty, or there were no dispensers. I was carrying supplies and I had nowhere to set them near the dispenser. I forgot. It was an emergency. Yeah, but I wear gloves. As a change agent, that all sounds like an excuse, a justification, a way of rationalizing not following the change, rather than that's actually a report on the world in which the person lives, is telling you how it is. Which creates this trap we have, the trap of understanding. What do I mean by a trap of understanding? Well, let's have Dilbert explain it to us. Did you ask the lab if they have a way to test traffic loads on our prototype? I met with them for an hour and explaining what we need that we need traffic load tests. But you didn't actually ask if they could do the tests. Well, no, but it's their job to do the tests, and they would have mentioned it if they didn't have a way to do it. But you didn't ask. That was the context of the meeting. If they couldn't do that sort of thing, that test, they would have mentioned it sometime during our hour together. Maybe you should ask. Okay, I'll ask. Are you freaking kidding me? I wonder why you didn't ask. How many of you, well, I'll do it this way. The trap of understanding. The trap of understanding is the belief that when people understand or know something, they will act appropriately based on that understanding or knowledge. Change is both emotional and factual. Emotions generally win. Facts do not convince. Understanding may be necessary for action, but it's not the source of action. How many of you in here would like to be in better physical condition or healthier than you are now? Raise your hands. Now, if you have absolutely no idea how to do that, put your hand down. That tells you something about the power of understanding. It's not that people don't need knowledge in order to do things, it's just not the source of action. Mark Twain once said, "It ain't what you don't know that gets you into trouble, it's what you know for sure that just ain't so." I'd like you to consider that we're trapped in this particular problem, that we operate this way with regard to change, and as a result, we end up with insanity. Doing the same thing over and over, expecting a different result. In the area of organization change, the trap of understanding is pervasive. It leads to unfounded expectations and the belief that something's going to happen. In order to make anything happen, if you really want people to do anything, you need a different type of conversation. It's what we call a performance conversation. It's the only conversation that actually commits people to action. It doesn't guarantee they'll act, it just commits them to action and gives the foundation for management. Performance conversations involve making an agreement with people, and they have a particular structure to them. This is the sort of the canonical form. Obviously, it can be done in a different sequence. But I'm requesting that you, A, whatever it is I want you to do, whatever I'd like you to provide, by a particular due date, and then why I want you to do that, or what it contributes to, or what difference it makes. So it answers the questions, what you want, when you want it done, and why you would like it accomplished, in a context in which it's of value to them. The last set of conversations, and the key to actually managing a change and implementing a change successfully without authority, without position, is through closure conversations. Closure conversations are conversations that complete the past. They don't dwell on the past. They don't in any way criminalize the past. They simply acknowledge it, address what's happened, and then move forward. These are very, very powerful conversations, and they're among the least used in organizations, particularly in the area of organization change. They create accomplishment, they generate satisfaction, and they build accountability. This is the place where if I'm looking to develop a relationship with you, I'm going to be using these two conversations. I'm going to use all four conversations, but if I'm a change agent, one of the things I'm going to be wanting to do is have you make promises to me, which I'm now going to manage. I can manage an agreement independent of my location, and I can manage an agreement independent of my authority. But in order to have it actually work, I need to have some way to create closure, which means I need to be able to manage or keep track of what's going on. The most powerful thing you have available to you is actually making requests and following up on those requests in a reliable and consistent way through closure conversations. So there are four, what we call the 4 A's of a closure conversation. Acknowledge what's happened. We had an agreement. You said you would do this by this time. You didn't do that. I said I would get this accomplished by this time. I didn't do that. Appreciate. I want to thank you for the work that you did on this. It was completely out of the ordinary, and it was completely inappropriate. Excuse me, completely appropriate. Completely appropriate that we be able to get that accomplished. Apologize. One of the things I learned as a college professor is that faculty frequently never said they don't know or would apologize for something in front of their students. I learned it's very easy to apologize and very effective. Amend. What you amend are agreements. Can you remake the agreement? Can we recommit to something? Not out of a you didn't do it, I didn't do it, but out of we didn't get this accomplished kind of position. All four of those, a closure conversation always involves one or more of those conversations. So, in closing on this, I want you to consider that all partnerships in change, regardless of positions of authority, responsibility, are built and maintained through the conversations you have with other people. When you listen to Peggy, I'm going to invite you to consider that what she's explaining to you is a fundamental success resulting from her ability to significantly shift the nature of the conversations and what people talk about in a unit. So she has an advantage of being in a position of authority, but as consultants, my wife and I never had any authority, but had lots of responsibility for supporting and having changes actually occur. So now you have the background theory. Peggy's going to give you the truth.
Good morning. Hope you can hear me. My background is I'm the manager of the surgical intensive care unit. And for many of you know that patients in the intensive care unit probably have the highest risk of hospital-acquired infections because of the nature of their problem. They're on ventilators. They certainly have a lot of devices and open places, Foley catheters, IVs, that put them at risk for infection. So they are an extremely vulnerable type of patient. I've always worked with ICU patients from the time I was 22. 30 years I've been in nursing. And I always remember a first quote someone gave me and said, our job is to protect the patients from anything while they heal themselves. And so what I always remember is that quote is that we have to protect them. It's our job to protect patients because they're very vulnerable. So I manage a surgical intensive care unit. It is a relatively small unit for some things, but we have a huge amount of opportunities for hand hygiene because it is an ICU and they are surgical patients. It's a 12-bed unit. I have 36 full-time, they call them full-time equivalents, which I refer to as my nurses. We have 3 clerical staff, but then I have hundreds of people that come through the ICU. Infection control practitioners, transporters, food service people, physicians, millions of people that come in and out through the ICU that don't actually sit under me. They are not my employees. So I don't necessarily have any authority over them. Not that I don't wield some power, but I don't have any legal authority over them. It is an open unit. Open units are an ICU where some closed units, like we have some closed units, like a burn unit, where they only take burn patients. An open unit will take overflow from medical intensive care patients, from cardiac, from any of the other areas within the hospital. Typically, though, because it's surgical, we will get patients that have been to the operating room and have a surgical wound. It could be from transplant, which puts an additional risk of infection because they're on immunocompromising medication. So again, another high-risk population. It's taken a long time, but I have a high-performing staff. It's been a long process. About the time we started electronic monitoring, we also started to work on a culture shift. We moved our unit to another place within the hospital, and I was released from 4 other jobs. And that's when actually I could shift the culture, because I could focus on one thing, and that's the staff, and I think that's been pivotal. Just to give you a little more idea, we're a unionized environment, and if you know anything about that, sometimes there can be adversarial situations when you have union versus leadership. And again, that was another hurdle I had to overcome, and it's been very successful. And our culture was not always so great, and if many of you worked in a hospital know that there's some work environments where people are less than friendly, they're bullying, they're challenging to work with. In fact, one quote from a nurse who had to float to our unit said, "I'd rather drive my car into the viaduct than float to your unit." So I thought, oh my God, because I surveyed everybody who floated into the unit to get their opinion on that quote, always sticks with me. because I thought this has to be fixed. There's got to be a way to fix this challenging problem. And so I came from a standpoint of what can we do to change the culture? Not strictly for improving quality or improving hand hygiene or preventing HAIs, but really for how we can make it a better place to work, where not only can people provide good care, but they can do it in a work environment that's pleasurable, enjoyable, and someplace they're proud to work in. So in January of 15, which is a little over 3 years ago, we began electronic monitoring of hand hygiene. Prior to that, and I'm sure many of you know that, we did direct observation, they call it, which means we would do secret shopper and somebody would watch to see if people were using the hand hygiene or washing their hands. And invariably, we scored very high, 95 to 100. And the reason why that is because it's a Hawthorne effect. If you know the cop is hiding under the viaduct, you're going to go with the speed limit. And people are responsible when someone's watching to do what you're told. But this is a 24/7 operation in a hospital, not for the 20 minutes we're doing direct observation. That's just a snapshot in time. So we had to do continuous monitoring. Many of you know in intensive care, we often put an arterial line in. That gives us a continuous readout of someone's blood pressure versus a spot check. If you go see your doctor, you're a little nervous, you might have higher blood pressure. That's kind of analogous with the direct observation. It's not a really accurate reflection of what the continuous rates would be within the environment. So when we switched, we had to talk to the staff. This was about the same time I was dealing with a lot of challenges with staff that were resistant to change, staff that were challenging me on everything. And what I looked at is some of the staff, you look at all of the staff you had, some of the staff were really able quickly to make an adaptation. Others were sometimes been there a long time, 30, 35 years. Others were totally resistant to any type of change. And what I looked at when I looked at the staff of anything is some people will stay and become a part of the change, and other people will decide to leave. And that's not a bad thing. Sometimes when people leave, the newer people come on and the process change. I did have many staff that stayed and adapted very well. So it wasn't a complete turnover of staff. About 25 to 30% left, but the remainder were the existing staff. Now, they were incredibly challenging to me because they were all like, I always wear gloves, I'm busy, I can't do this. Another thing in an ICU is that nurses already feel that they have to police the doctors about 1,000 things. We, in our hospital, have a process which it does work, but it's a challenge, where when a doctor's putting a line in, the nurse is the observer, basically pointing out, you need to change your gloves, you broke sterile technique, you need to do this, you need to do that. And it puts us in a challenging position, but it is protective to the patient. So the nurses felt when we were adding hand hygiene monitoring, that would be another thing, that they would be responsible to hold other people accountable, which they do. But we had to give them a mindset of, again, it's all about protecting the patient and doing our job, and that our job is to monitor them 24/7 when we're there. So it definitely was a challenge. When the hospital came to me about it, unfortunately, I've always been kind of an A student. I thought, oh, 75, C's get degrees. This is going to be easy peasy, no problem. Then I get my first score of 29, and I'm totally deflated, and so is everybody else. So realizing you were doing the direct observation and you were 95 to 100, which was this inflated number, obviously, and then you get the real number of 29, and you feel like, okay, now you realize this is a marathon, not a sprint. It's going to take us a long time. So if you look at our numbers, you can see over the course period of time on the slide that it took quite a while. I mean, we made some direct headlines in the beginning, and then it took a long process before as the change process took place over the 4 years. We've been 3.5, 4 years. We've been working on a culture shift within the unit. So, but I think I want to reiterate that the culture change is what actually drives it. It's not strictly related to. I mean, the hand hygiene is the outcome. The culture change is actually how you achieve those goals. So again, we looked at all of the things you run into. The negativity, I'm too busy, how will we get there? We'll never do it. I'm already wearing gloves. Why do I have to make everybody else do their job? They should just do it automatically. Lots of resistance to that. And you just slowly chip away at it. I always tell people in my relationships with the staff is that That's how you handle each conversation. There's going to be challenges in your personal relationships as well as your work relationships, but you're continuing to build that forward partnership as you move forward. So to me, it's all about the staff. I started with the ACN's healthy work environment to see where we are going and where we could go. When we meet their needs, they meet our needs. I'd meet individually with each and every staff nurse. What can I do for you? How can I make it better? Is there anything you need? And then listen to them. They have lives outside of here, and it's a work balance situation. But if you're happy and you can meet the needs of your personal life, then you're a better employee and happier in your life. So small things. A lot of our nurses it's a female-dominated profession, come back from maternity leave, and they wanted to work the weekend so they could have someone to watch their children. Well, we made an agreement with them, or as the individual cases, case-by-case basis. So as you get the hours that you want, you're a happier employee. Do you have enough staff on your unit to meet the needs of hand hygiene? So listening to what their concerns and needs are, as we began to listen to what their needs and concerns are, then I would bring up issues within the unit, and it became a reciprocal agreement, a partnership. And one nurse said to me, and it was an aha moment for her when I was talking about hand hygiene. She goes, well, you know, if it's important to you, it's important to us. I'm like, wow, that was a really powerful message. I realized then that I had to tell them why it's important to me, for our patients, for the protection of our patients, and we make it clear to them of the importance of what we're doing. I always tell people about hand hygiene. It's not like in nursing you can rush into the room and do CPR or defibrillate somebody and instantly they get better. That is the Hollywood moment, and we do that occasionally, but very rarely. Most of the time, we're the unsung heroes in that we're doing the small thing that protects the patient. And think about this. Think about a 25-year-old nurse having to talk to a 40 or 50-year-old attending and let him know that he hasn't washed his hands, how challenging that might be. So that takes a lot of courage, and it takes a lot of internal sense of satisfaction and a pride and ownership of what you're doing in your job. So I really believe it's the ownership of the unit. I say it starts with first happy staff, then it moves to engaged staff, and the third step is ownership. Right now, today, they're taking care of intensive care patients, making a difference, and I'm here, 1,000 miles away. So I realized that it wasn't about when I'm there. It's about them being 24/7. It's not how well it functions when the leader is there. It's how well it functions when we're not. So they need to drive the change. They're the ones there 24/7. So what we've seen is a huge culture shift. They began to support each other, less turnover, the same consistent staff, and all of a sudden, all of our quality indicators improved. I'm proud to say that we haven't had a central line infection in 2.5 years. We haven't had a transmission of a C. diff in 2 years. These are incredible numbers. It's very hard to link that directly to hand hygiene, but you can tell that there's some component of it that has to be within that. Recently, she mentioned we received a beacon. For many of you who don't know that, it's like the Olympics of ICUs. There's gold, silver, and bronze, and very few ICUs have it, and we were lucky enough to receive a silver award this year for our quality, and it's an incredible accomplishment, and it's never been done at the UFC in the entire existence of time they've been there, so that's a very huge process. One of the ways that we've really helped with the direct hand hygiene situation is we've partnered with infection control and our hand hygiene team. We do a brief 15-minute call once a week. We talk about where we are with our weekly rates and our current rates. We also talk about our challenges and our opportunities and also our strengths that week. We have multiple ICUs, and all the ICUs are on one call, and all the general floors are on another call, so that we're comparing like entities, and then you can share your ideas and discussion. We first started this probably the first couple of weeks. Our unit was the unit that came up with the hand hygiene champion, and we later changed the wording to sheriff, and I'll kind of explain that why later. But what it means is that someone each shift would be responsible for reminding the thousands of people that walk through the ICU that would take ownership. Much like if people are in a family, everybody has a job after dinner. Someone empties the dishwasher, somebody sweeps the floor. In the ICU, we assign everybody a task. Someone checks the crash cart, someone checks the monitors. This person's job is to assure hand hygiene for that 12-hour shift. Then we have a brief huddle at the end of the day, and they report out on their scores and how well they did, what their challenges were. Sometimes we have dying people in the ICU, and then we have tons of family in and out. It's very hard to tell someone who has a dying relative to be sure to wash your hands to protect the patients, other patients, when they're going through this crisis. So there are some huge opportunities and some challenges when you work at an ICU. Now, in these calls, all the unit leaders are there from all the ICUs. In addition to that, we also engage the staff, have our champions there, talk about it. Once we started the champions in the surgical ICU, it spread to the other ICUs. And so I always say imitation is the highest form of flattery. So if someone takes your idea and uses it, it helps more patients and spreads the positive responses throughout the building. So that's one of the ways we've shared all our good ideas throughout the hospital. I mean, this is kind of a busy side, but it kind of basically looks at a lot of trial and error. What we did, we got together with unit-based staff. How could we work on these processes? We go up and down. Some things work, some things don't. Some things transiently work and then go down again. One thing we tried, which did work, but it was too challenging for the patients. We had a little monitor like outside that would say, as you walk across the threshold, wash your hands, please wash your hands. And it was irritating to people trying to sleep for that to go off 30,000 times a night. So even though something works, if it doesn't meet the other needs of the patient, it's not necessarily something you can do. Now, something that works in one area might not work in another area. But we often stole from the operating room. There's a little bar that says you can't cross this line in the operating room without the hat on, the booties, the gloves. We tried that as well, and that was very successful. So you have to do trial and error. What works in one area might not work in another. But again, sometimes it's just letting the staff see what's working and see how it's successful and sharing that with everybody else. So tons of different ways you can look at hand hygiene. I shamelessly lose my little dog. She's 3.5 pounds. And what I've learned about this is in relationships, you have to share it with people to have it. We share our lives with people. I share stories about my dogs. People who have little children or whatever. When you do that, you humanize yourself. You want to engage with people in a level that they can understand. We had lots of issues with our physicians, so we started to have covered dishes and invite them to it and say, oh, we're having a Mexican day, we're having a special day for this. Celebrate all things in the unit, like someone achieving a degree, somebody having a baby. Those are successes, and those, when you humanize yourself and bring yourself into the relationship, you're more apt to be forgiving and accepting someone. So when the nurse then has to tell the doctor that he broke sterile technique, he already sees her as a person and doesn't get easily upset. So those relationship building has hugely impacted us. The other thing I've learned about advertising is whenever you put like a cute little animal or something, it's very visible to visitors. When I put this in my unit, everybody asked me through the hospital, can you share the picture? Because they noticed visitors were more attentive to it, little children. And so sometimes if you look at advertising, you'll find a good-looking person, a little animal, a child. That's very good for marketing. So use whatever you have to make yourself successful. And one of the reasons we call it a sheriff is most people feel in nursing that we're always policing the doctors, and they said they didn't want to police the doctors. And I said, well, let's call it a sheriff because a sheriff serves and protects in more of a small town kind of flavor versus a policeman with a gun versus we're protecting our patients from HAI. So the sheriff really works. And the staff actually have a little sheriff badge that says Hand Hygiene Sheriff, and they wear it when it's their responsibility, and they pass it from shift to shift. And it's been hugely successful. It seems like a small thing, but people are like, they see that, and they're obedient to that. We do a lot of just-in-time coaching because we have thousands of employees. You can imagine there's a lot of turnover, different groups of doctors pretty much every month. So one of our nurses, and I always make it staff-driven, meets with the new group of doctors and gives them the lay of the land, the rules, don't touch our ventilators, please wash your hands, all that. And they give them a little bag, and it's got aspirin in it and antacids, and it says surviving the SICU. So they make a joke of it again, and the physicians love it, and it engages them, and it makes them more responsible. So that's a benefit to us. Again, using humor, using whatever you have to build those relationships. What I tell the nurses is you can tell the doctor something in a nice way. You don't have to say, you didn't wash your hands in a nasty way. You can like, remember, you're protecting the patients, and do it in a positive way. Anytime you have any conversations with anyone, when you say, I'm calling you because I'm concerned about our patient. When you lead with that, lead with the patient, you're creating, it's our patient, a relationship, and it's important to all of us. That's a huge initiative. It might be semantics, but just like we do not call a float in our unit a guest, if another nurse comes from another unit, we call her an honored guest. That same nurse that drove her car into the viaduct says she loves to come to our unit because she's treated with such respect. They make sure she gets first choice of her patients. She goes to her own unit for lunch, treated with kindness and respect, because there's a reciprocal agreement in being a guest. You come to my house, you bring me a bottle of wine, you compliment my decor, I give you a nice meal. There's a guest host responsibility. It's the same thing. So again, it's all about partnering with people and making sure they feel that way, treating people the way they want, or the way you'd want to be treated. So that relationship building is huge. All of the messaging thing is done from as much positivity. We have quality representatives that come, all of the messaging to the staff. So we live in a multi-generational, people text, so we text people, we call. The secretaries are able to text all the nurses on their phone saying, the doctors are coming around, everybody be responsible for hand hygiene, reminding them about that. Or we have a new admission, everybody be careful. We know where our weak spots are during admissions, during codes, during end-of-life processes. So whenever we know that, we're keyed into that. Sometimes we even station one of our clerical staff at our hand hygiene device to assure that she's got a little hand clapper and she holds it up so it's quiet, and then everybody who walks through does it. Sometimes we also we have rounds of doctors. The MICU comes through, it looks like, who is the brass band? There's like 20 different doctors and people with them. So we assign one person with that group. Sometimes it's the attending, sometimes it's the medical student. But that one person has the hand hygiene signal, and they're responsible for minding everybody on entry and leaving. And it's almost like you look at it like a duck with the chicks behind it. As one person does it, they all follow behind. People don't want to be the one not following the rules. So that's one of the initiatives we've used as well. Lots of different education. People say, well, I don't read my emails, I don't read my text. Well, we put a go and no, a bathroom wall education. It's kind of funny because everybody goes to the bathroom. So we looked at where else can we impact people with education, because you can't say I don't go to the bathroom. So you can't say you missed that education. So visitors are a huge challenge in an ICU. They're just a monumental process. But when we meet with them for the first time, we talk to them. We talk to them on the level of lay people, not medical people. And we say going in is for your loved one, is coming out is for you. It's a simple concept. You're protecting your loved one and you want to protect yourself. It's a hospital, and we've gotten some good results for that. We have signs in the room. We also put it on the backs of the visitor passes. Anything you can multiple. Sometimes people say you have to hear something 7 or 8 times before you get it. Additionally, when people come in and they've gotten the shock that someone's in a car wreck or someone's had a stroke, they're at such a high anxiety level that you might tell them the first time. I said, I told them an hour ago. That doesn't mean they're aware of it, or they're not deliberately trying to not listen to you. They're just at such a high anxiety level, it's not sunk in. So it takes multiple times, multiple reminders. That's why we use our clerical staff to help do with that. Again, I always remember some of the people that take your information and go somewhere. We have everything scanners, so we scan everything for the protection of the patient. We scan ourselves, scan the medications, everything's scanned for safety, which is good. But that means we have people to service the scanners. One of our gentlemen that comes in, he's in IT, he's not in the medical profession. And I noticed him going from room to room, check the scanners without using any of the hand hygiene. And he said, well, I'm only touching the computer. And I go, that's the same computer the nurses are touching and then touching the patient. So anytime you touch anything in the room, the scanner, which the nurse touches the patient's wrist, puts the patient at risk. And then I said, so you are a part of preventing infections. And he said he took that information and he's religious about it. Every time he goes in a room, he wipes down the scanner. He's very religious. And I felt like this was a person that spread this information throughout the hospital to all the people in IT. So then I thought of an idea as like, have a champion in every department, whether you work in food service, transportation. These are people, so when they have their huddles and their staff meetings, they can say, this is how you, who work in this department, can impact infection within the hospital, throughout the hospital. So remember, it's not just our medical staff that are in and out of the room. It's a lot of people that touch the patient, and anybody that touches the patient puts the patient at risk. So again, we always have to tie everything back to why we're doing what we're doing. Most people have had an experience maybe with a loved one or relative. I personally have had a relative that had an HAI infection and subsequently died, so it's near and dear to my heart. Again, when you share that information to people, they're much more believable, but remember, you can't see infection, so it's something that you have to bring up clearly pretty much each and every day. Again, you can look at the results. Again, we've looked at CLABSI, CAUTI, C. diff, and had a huge impact on those. Now, again, it's hard to tie that directly to hand hygiene, but it is one of those indicators. And also staff holding people accountable. One of the side byproducts we noticed is we also had a very low sick call rate. And staff said, well, that's because you're so good about giving us our time off. And I go, but I was good about giving your time off before we implemented this. So what we felt is we had nobody, none of the patients were calling in with colds and flu as frequently. You can't tie that to it exactly, but that is one of the ways we transmit colds and flu. So we have had a very low sick call rate as well. So, so these are some of the ways that we've looked at how the outcomes, but to the staff, not working short because their coworker is sick is huge. So then they can feel they can deliver better care. Always bring back how it's going to benefit the patient and the unit and the staff. So that's always important. Now, this is a huge slide, and it tells you a lot of information. You can see where we've gone from the beginning, which I said was terrible, was 29%, and how we've moved and what processes we've done to bring that about. I do say that it goes up and down, and it's recently, as of May 1st, we added the trauma patient, and that's a new experience for us. So again, you're going to have challenges, much like you have challenges in your personal relationships. It ebbs and flows, it goes back and forth. So you constantly have to keep it on the radar and keep the process moving forward so that you know. It can't be something you forget. That's why we meet every week for our brief call. So some of the things you notice in a hospital-wide improvement with just a small improvement in hand hygiene, only 1% of the number of MRSA and C. diff. To the hospital, which of course the bottom line is money, this saves a ton of money. And PPE as well as caring for those patients with those infections. And this is a quote that really kind of why I like to sum up my leadership. I think that leaders become great not because of their power, but their ability to empower others. Because I do work in a 24/7 operation, it's something that they're there all the time, saving lives, making a difference. Constantly have to remind them it's the big things as well as the small things, which might appear small like hand hygiene, but overall can make the difference in a patient surviving their disease process, preventing infections. It's a matter of, I always make a joke, if you're going to be a transformational leader, the first person you have to transform is yourself. So I think it's important that you practice what you preach. So if someone ever tells me I'm very religious, because I'll take the time, I go in and interview all the patients, and the first thing I'll do is use the hand hygiene, and I'll say to the visitors, well, I use the hand hygiene, and I encourage you to remind staff and do it yourself when you're coming in and out of the rooms. So our journey started with hand hygiene, but really it was about the culture shift. And for me, huge benefits to me beyond, which were great, the hand hygiene and improvements in all of our quality indicators, but also I had a hard time recruiting people now, and I rarely have a job opening, but the last time I had a job opening, I had 50 applicants. They were literally stalking me for a job. So that was really a very positive thing. And I mean, word of mouth in a hospital tells the telling tale. If people want to work for you, it means you have a high reliability, a positive work environment. And people enjoy coming to work, so that's always a positive thing. So again, I just want to tell people that it's really about keeping the staff driven, keeping them aware. We put up, each week we put up a graph, and whoever has the highest hand hygiene sheriff award for the week, we give them a free lunch. We talk about the positives that we're doing. We're constantly giving praise and encouragement to the people. As people respond to positive affirmations. You know, some people think people work for money, and of course we all need a job, and so we do work for money. But there's a lot of people, money isn't the only thing that drives us in a job. I don't think Bill Gates or Oprah Winfrey, they need the money. There's something else driving people, and it's a sense of inner satisfaction in what you're doing. So we save lives for a living and working with patients. So constantly letting people, and reminding people of that their job has huge value, and it makes a difference, that makes the difference when you work with people. I think that at least that, and that's the authentic part of leadership. This is what really drives change. So for me, I think telling people about what they're doing and how important it is makes all the difference, how the successes they're having. And I think that's about it. If you can answer any questions you might have.